Assalamu alaikum.
Waalaikumsalam.
Good morning. Let us start by الكتاب. Okay, who will be the first one to present?
I am Kamila Iman with Anis Amira. Okay, shall we
Yes.
start now?
Okay.
Okay, Assalamualaikum. Okay, today we will be role playing on a case on respiratory system. So we'll start the role playing. Okay, wait. Okay, Assalamualaikum. I am Nik Kamila Iman, a third year medical student. So today I would like to ask you a few questions regarding the patient's condition. Is that okay?
Yes, it's okay.
All right. So firstly, I would like to confirm the patient's age, the patient's name, age, and also your relation with the patient.
Okay. The patient, I am the mother of Lukman, which is 4 years old.
All right. Okay. Thank you. So what brought you and your son to the hospital?
We came to hospital because my son has been coughing, and I noticed that he have rapid breathing for about 2 days.
Okay. So about the cough, the cough started 2 days ago, right? Did the cough start suddenly or gradually?
Suddenly,
Suddenly. Was this the first episode of cough?
no.
Okay, it's not the first episode. May I know, was the cough dry or productive?
I noticed it is chesty cough, but there's no expectorant.
There's no expectorant. Okay. Did you notice how did the cough sound like? Was it like a normal cough or barking sound?
What you mean by barking sound?
It sounded like a barking of the dog during the coughing.
Oh no, it's just like a normal cough.
A normal cough. Okay. All right. Did your son also experience any fever or any runny nose?
Yes.
He had fever and runny nose, right?
Yeah.
Okay. Did you notice that he had any hoarseness of voice?
No.
How about sore throat?
Sore throat, no.
No. Was there any other symptoms that he had?
I think that he also I noticed that he
Voice is not so clear.
Is it my voice?
Adjust please your microphone.
Hello, can you hear?
If not needed to open video, you can do so. We can hear you, please. Yes, now it's better.
You can hear me better? Hello?
yes.
Yes, now it's better.
Oh, sorry, my internet is maybe it's not. I have to turn off my camera. Oh, wait. Okay. Okay. If it is unclear, you can tell me.
Okay.
All right. Again, what were you saying? Was there any other symptoms?
I noticed that he vomit after he cough.
He vomit after he cough. Alright. Um, did you notice for the cough? Was there any triggers to the cough?
Triggers. You mean what he doing during the cough?
Yeah.
I think he started coughing after that he play outside the house.
So he started coughing. Was the cough worsened at any particular time of the day
And it's quite worsen at night.
at night? It worsened at night. Uh, did you do anything to relieve? Was anything been done to relieve the cough?
Um no,
Was
no, I didn't give him any medicine.
You didn't give him any medicine, alright? Um. From the past 2 days, was the cough worsen? Did the
Oh,
cough worsen?
yes. On the second day, the cough worsened that I took him to the nearest clinic.
Okay, you took him to the nearest clinic. What was he given anything at the clinic?
He was given nap. Um, yeah, I noticed he got better after the nap.
He got better after then. Alright. So you mentioned that he also had fever. When did the fever start?
And during the same day that he experienced coughing.
Was the fever started suddenly or gradually?
I think it's gradual,
It's gradual, right? Were you able to record any temperature?
but I feel that he is quite warm to touch.
Quite warm, right? Do you notice that he had any chills or rigor?
Not that I noticed.
No, he did. Okay. And then about the post-tussive vomiting, does it happen every time after he was coughing?
Yes.
Okay. Did you notice the content? What was the content of the vomiters?
I think only like the food that he ate before.
Okay, the food. There was no blood or anything.
Or no.
Okay. Can you quantify or what was the amount of the vomiters?
I think only about 2 to 3 spoon.
2 to 3 spoon.
Only a little.
Okay. How frequent did he have this symptom?
The frequency maybe about 7 times.
7 times in a day.
Yeah.
Okay. All right. You also mentioned that he had rapid breathing. When did the rapid breathing start?
Rapid breathing. I think on the second day.
On the second day. Okay. Uh, did it start suddenly or gradually?
Suddenly.
Is this the first episode of rapid breathing?
No.
No. Right. Um, was he doing anything during when he had that symptom?
No.
No, it occurred when he was resting.
Yeah.
Okay. Do you notice was there any chest recession?
Certification. Yes. I know. Yes. I noticed.
Did you hear any wheezing or any wheezing?
What you mean? Oh,
Wheezing is like did you hear when he was breathing? Did
yeah.
you listen heard any whistling sound?
Oh, no.
No.
Not at this time.
No. Oh, what you mean you've heard it before?
Yes, I heard before.
All right. Um, is there any? Did you notice he had any nasal flaring?
Nasopharynx? No.
No. How about any bluish discoloration, especially at the lips?
No, also.
Okay. Was anything been done to relieve the rapid bleeding?
No.
No. Okay.
Wait, I take him to the hospital, to the clinic.
You took him to the clinic and what?
Yeah. The net, the same and the cough.
He also received a nebulizer session. Was it relief after the nap?
Yes.
It was relief. Okay. When he was having the rapid breathing, is he able to talk as usual?
Yes, he able to talk
In sentence or phrases or in words?
in phrases.
In
He's
phrases.
still quite active at that time.
Still active, correct. Okay. Do your son have any allergic rhinitis or any eczema?
No.
No. How about anyone in the family?
His
Yes.
brother and his sister has eczema.
His brother and sister. Does anyone in the family has asthma?
Or his father.
His father has asthma, right? Um. Okay. Uh. Does anyone at home? Does anyone smoke at home?
Smoke. No. Yes, yes. My husband is a smoker,
Okay.
but he smoke outside the house.
Husband. Alright. Um. Is there any does your son have had any history with of contact with a sick person?
No. No, at this time.
Any recent traveling?
No.
Okay. Is he living in a dengue endemic area?
No.
Okay. Right. So you mentioned that this was not the first episode for the cough and also the rapid breathing. So when did the first episode occur?
The first episode, I believe that it was last year when he was 3 years old.
When it started when he was 3 years old. Okay. What usually triggered the symptoms? Like what was he doing before usually?
Usually, I think like also like this fever. He have fever, and then I think because of the dust in the house. That's why. Yeah.
Okay. And then on average, how frequent does the symptom appear? How many daytime symptom does it how frequent does the daytime symptom appear in a month for example?
Mine I think only once.
Once a month. How about the nighttime symptoms?
Mm, like it's. I think I feel that it's less than once. Lesser. Yeah.
Okay. Um, did you was anything been done to relieve the symptoms when
Or before this,
yeah before this?
I took him to the clinic, and nap also. Then it was relief.
Oh, alright, that's good. Okay. And then in regards to his current
You have 2 minutes to finish.
alright. Um
3 minutes to finish.
and is this the is was he has ever been hospitalized before?
Oh no.
No. Uh um is he on any medications
No.
besides the nebulization? No.
Oh no.
Is his immunization completed up to date?
Yeah.
Alright. Um, can you describe what happened during his birth? Before, during, and also after his birth.
Antenatal before. This nothing. It's normal, And then my son was born at 38 weeks, and also during uh, apa, due to via the vaginal delivery, and I think he was about 3.3 kg, and after the birth nothing, it's normal.
Right. How about his development? Is it appropriate for his age? Is he growing well?
Yeah, yes, he's going well.
How about his nutritional? How about his diet? Is it well balanced?
I think it's well balanced. Yeah.
Okay. Is there any other medical illness in the family besides what his father and sibling had?
Medical illness, no.
Okay. And then may I know where do you live, and also what do you and your husband work as?
I live at Gambang, Pahang. Mm, my husband is a businessman, and I am a nurse.
Okay. All right. So I guess that's all. Thank you for your cooperation.
Okay.
Okay, so thank you, Camilla. And now we are going to discuss can you summarize? Don't repeat, just summarize your history taking from the patient.
Okay. Um. Okay. Luqman Darwish, a 4-year-old boy, was admitted to HTAA presenting with cough for 2 days and rapid breathing on the day prior to admission. The cough was associated with 2 days of fever and runny nose, and also whereas the rapid breathing uh, is associated with a subcostal recession. However, there was no wheezing, uh, nasal flaring, or any bluish discoloration. Um, he had previous episodes of wheezing, shortness of breath, and also coughing, and required multiple nebulization for it. He also has a strong family history of asthma and eczema.
What do you mean by strong family history?
Um, for the eczema, because he had two siblings that had eczema. For asthma, okay, it's not strong family history. Only his father had asthma.
Did he got any eczema or not?
Ah, sorry.
He got any eczema himself before?
No.
Okay. So what's your working diagnosis now?
My working diagnosis is a newly diagnosed mild persistent bronchial asthma secondary to viral infection.
How can you prove that?
Ah,
How can you prove that?
mild persistent. Because he had exercise induced symptoms.
No, to say it is persistent or intermittent. What is the difference between them?
The intermittent, if he had no exercise induced symptom, then he is under the intermittent bronchial asthma. But since he had the exercise induced symptom, and also the frequency of the daytime and nighttime symptoms.
Yeah, so you must ask about the other criteria. Did you ask about how many times he is coughing during the daytime per week? Before that, and how many times he would cough at night time? How he is using the reliever medication? We have a very clear table in our pediatric protocol about that.
Okay. Um.
Okay.
Can I ask something? Um.
Yes, of course.
He had no exercise-induced he had exercise-induced symptoms, but the frequency of his daytime symptom and also the nocturnal symptom does not fit in the mild persistent group. So how
So
can
you must put
Okay, I found.
about the incident. So you must come to the reliever medication. If you open the table, you will find the cough during the daytime, during the night time. And then what about the reliever medication? So you must ask per month how many times you are using it. Okay?
okay, alright.
To come to the conclusion that is persistent asthma. Okay? And now what about the severity of the attack itself? Now we know the course may be mild persistent asthma. Okay. What about the severity of the attack?
The attack is severe since the rapid breathing. He is breathless. That is occurs at rest. Is
Is
it?
it enough? So you are getting one parameter and good our final decision?
Okay, no. Or he talks in phrases and in oh, okay. Maybe moderate.
No, we are not working like that. We must be clear cutted. What is the criteria to say mild or moderate? I think your colleague may present that after, but it is very important for you during your history because if you are not oriented about that, you are not going to ask. If you didn't ask the family about all criteria for the persistent asthma, we are not able to come to the conclusion. If you are not asking also about the severity while admission to the hospital, what about, as you said, the severity of the recession, what about the response to the treatment, what about his pulse oximeter, even you must present to me about the pulse oximeter, the peak expiratory flow rate, because uh, to handle the asthma accurately, you have two important pillars. One pillar or one table which can guide you how is the course of the asthma. And at the same time, this sometimes is not identical with the severity. It may be someone have intermittent asthma, but when he got an attack, it may be life-threatening. No guarantee for that, okay? So we must be able to squeeze the history for 2 points, as you did with the family history, because it is very important.
Right.
Why you said it is due to viral infection?
Because he also had fever and runny nose.
Okay, fever and runny nose and cough and recession and tachypnea. All this is a marker of the severity of the attack. But how can we differentiate between viral and bacterial?
Probably the nasal discharge itself. For the
Okay, what
viral,
else?
um, they um, the
So
cough.
let us modify the question. What is the investigation you will consider now to do if you just see the patient on the emergency department?
Chest X-ray.
Okay, what you are searching for in the chest X-ray?
Oh, any
blood count, doctor?
Pneumonia, any consolidation of the lungs.
I will. Yeah, good. So we must look for the cause or the asthma itself. So we must know now. Okay, Camelia,
Yes.
if you are looking for asthma in the X-ray, what did you suspect to find?
Hyperinflation of the lungs.
Any other?
Mm, not sure.
Be complication of the asthma. There may be some complication, atelectasis, collapse, pneumothorax, like that. Okay, so you must know what about the chest X-ray and how can read it to get differential diagnosis. What about other investigation,
Full blood count.
Amira? Looking for what?
Looking for the white blood cells. Signs of any signs of infection. For
Okay.
if it is bacterial, probably the neutrophils will be high.
Okay.
Whereas if
What else? What other white count you are?
the lymphocyte, if it is viral, it could be high.
Okay. What else is important also in the differential count?
The eosinophil.
What did you suspect?
Increase because of the increase in eosinophil count.
Okay, okay. So that is the way we must think about it. I will let your colleague now just present their OSCE. Did you prepare OSCE for asthma or not?
I prepare for respiratory system. Like
Can I see your presentation?
that's for question one.
Yes.
Do you see the slide?
Yes.
Okay. Proceed, doctor.
Yes, you can proceed. Yes.
Okay. So anybody want to volunteer to answer question one?
Me. What is the name of the device? So this is aero chamber used with MDI. Take this inhaler.
Okay, good. The so what is explain the steps to use this device? Proceed. Hello.
Uh, can I try?
Yes, you can.
Okay. So first, we take the inhaler, and then uh, before we use the inhaler, we need to shake the inhaler first, and then we will insert the inhaler's mouthpiece into the hole at the back of the spacer, uh, and then um, and then um, usually children will use with mask, so we need to put the mask on the mouth and nose of the children, and ensure that there is a good seal between the mask and also the cheek and also the chin of the children. And then uh, but before that, I forgot. The children need to exhale fully away from the spacer. Okay, and then we can put the mask on the children nose and mouth. Okay, so once we had put the mask, so we can release the medication from the metered dose inhaler by pressing down the canister, and and then uh, then the children need to breathe in deeply and also slowly to inhale the medication, the aerosol plume from the MDI. And then okay, and then what? Uh, they need to okay, and then the patient need to hold on their breath for around 5 to 10 seconds, and then if they need uh, another second puff for the medication, so they need to wait for 15 to 30 seconds to start the second puff. So uh, is it correct?
Yes, it's correct. So after we use this device, so do we need to brush the device during the washing? What do you think?
No.
Okay, correct. Good. Uh, Next one, Camila. This is the answer I provide. So why we didn't brush? We do not need to brush the device that to prevent the electrostatic that causes the particle of the medication to attach to the wall and cannot enter the patient's airway the next time we use. So we do not need to brush the device. We only put it under running water. Okay. Next question. So question 2. So 3-year-old boy is brought to the emergency department with the history of fever for 1 day with a sudden onset of stridor and also dyspnea. And on the examination, the boy is toxic looking, anxious and febrile, and also has drooling of saliva. His pulse rate is 150 beats per minute and his respiratory rate is 60 breaths per minute. So what do you think is the diagnosis of this 3-year-old boy? Hello, any volunteer?
Epiglottitis.
Yeah, true. So what is the causative organism for epiglottitis?
H influenza. Haemophilus influenza.
Yeah, correct. What about the common, not common, what about what you will find on the X-ray finding on the patient with epiglottitis?
thumb sign?
Yes. So we can find thumb sign on the X-ray. I didn't provide the X-ray, but it's because of the swelling of the epiglottis because of the inflammation. So we can find thumb sign. Okay. The next question. So this is the chest X-ray of an 11 years old girl with history of recurrent lower respiratory tract infections. So what is the diagnosis for this patient? Hello?
I think it is bronchiectasis.
So what's made you think is bronchiectasis?
Because I can see presence of dilations of bronchi. Is it correct?
Correct. Aisha, what is the state the symptoms of the diagnosis and any clinical signs for this patient might have?
For the symptoms, I think the patient may have like productive cough, dyspnea, um, hemoptysis maybe, and for the clinical sign, the patient may present and may have like crepitations, finger clubbing, and maybe ronchi.
Okay. So for the third questions, what is two possible underlying etiologies for this patient?
For the underlying etiologies, it could be due to cystic fibrosis, primary ciliary dyskinesia.
Okay, correct. That's all for the OSCE.
I have a question.
Yeah.
For question number 2,
At this level, if you have patient with bronchitis, you must comment about this patient has like bronchiectasis and hyperinflation of the chest. So you must comment about the clubbing. Is there any clubbing? Very important. Okay.
Okay.
So if here we get cystic fibrosis. So this is the importance of the history. Here is the repeated recurrent infection. Yes, current infection can cause asthma, but the presentation current infection, it is not the main like the like bronchiectasis.
Doctor, we cannot hear. We cannot hear you. Stop a little bit at the end. Doctor,
That's why. Yes.
we cannot hear you at the end before.
Yeah, I think there is problem with internet. You can continue, Amira.
That's all for Oski.
Okay.
Can I ask a question?
Yes.
Yes.
For question number 2, for the first question, what is the diagnosis? Can group be the diagnosis or be the differential diagnosis for this case? Because
Can
I
come back,
think
please, to the
the
second
patient had
question.
a stridor. Because I think the patient had stridor and also febrile.
Of course, yeah, this is the trick for the question. You can find now that all criteria of severe stridor, which is a viral, are present. Okay, which is okay, stridor and dyspnea, okay, and fever. But she stated now that there is a toxic looking, okay. He has drooling of saliva. If you found many items which is a toxic look or drooling of saliva, or a most important is the position, if the patient is sitting, okay, and elevating his neck, he cannot get his breath, and this picture is still in the Nelson. I mean, the patient cannot breathe normally, he cannot sit, he cannot lie, he is standing as if he is feeling that his neck is going to be blocked. All this you must rule out either epiglottitis or bacterial tracheitis also can cause like that. Okay, even you can say, if you need to give a clue that you suspect this patient has severe stridor, okay, so severe stridor to rule out epiglottitis or bacterial tracheitis. Don't forget that to have the rolling of saliva or abnormal position or toxic look, it need a very severe course.
Okay,
Okay.
I understand.
Okay. Is it all for you for asthma?
Yes, this is all.
No, I think asthma is not a simple condition. You need to open your pediatric protocol. I think it must be in the bucket of every one of you. Okay, and just go to the page 182, which is asthma. And all of you must have you must read all about asthma, and even after asthma, you have like a simple differential diagnosis, which is bronchiolitis. If a small baby got bronchiolitis with spasm, and the third one, if the patient has pneumonia, how can we differentiate between that? That's why I used to tell you, if you have a protocol, you must consider it in your pocket, please, or on your mobile, okay? It is very important to do the differential diagnosis, and all of you need to read it and give me confirmation that you did, okay? We have another one or two presentation.
One, doctor.
One more.
Yes.
Hmm?
One more.
Okay. Who will be the second group for presentation? You need to revise asthma. This is just, we know the title, but we need to go deep, please. Because asthma now are very increasing, and you must know what is the asthma predictive index? It is present in the third edition also. Okay, now خير what?
خير
yeah.
نادية.
خير نادية. Okay, خير نادية. Okay, good. Go ahead, خير نادية.
Yes. I'm the presenter. Dress another persons who become the moms to the. I know that. So, Bismillahirrahmanirrahim. Today I will present the case about the neurological system, and I'm sorry, because my my earphone is broken. So if you guys cannot hear me clearly, you guys can interrupt me in the session. Okay.
You are okay? You are okay? Good. Continue.
Fine.
Yes.
Okay. Sorry. Assalamualaikum warahmatullahi wabarakatuh. Is this Mrs. Ain, mother of Ahmad?
Yes.
Okay. I am Khairun Nadia binti Muhammad, year 3 medical student. Can I ask you a few questions regarding your son?
Yes.
Okay. May I know how old he is?
He is 1 year old and 8 months. 1 year and 8 months old.
Okay. What makes you come to the hospital?
My son complained. My son had fever and fitting for 1 day.
Oh. When did you notice your son experience fitting and fever?
My son had fever yesterday, and for the fitting, I think it is today.
Oh, okay. Did the fever started abruptly or gradually?
I'm not sure, but I think it is. I'm not sure.
Okay. Did you record the temperature of your son?
I record the temperature. I think it is about 38 degrees Celsius.
Oh, okay. Did you do anything to relieve the fever?
I went to clinic kesihatan because of the fever, and the doctor give the medication, but the fever still not subside.
Oh, okay. How was your child's activity? Is he still active or felt tired?
She remained active even though she had loss of appetite.
She,
He, sorry.
sorry. May I know, is the fever come along with the other symptoms?
Yes, that my son also experienced coughing and runny nose.
Okay. How long has he been cough and has the runny nose?
I think after the fever.
Oh, after the fever. Okay. Mrs. Aim, may I ask, regarding the cough, did you notice any characteristic of the cough? Is it like dry or productive, like had the sputum?
I think it is dry because there is no sputum.
Okay. How about the nature? Is it you think from the throat or the chest?
I think from the chest.
From the chest. Okay. Regarding of the cough, how was his condition when he coughing? Is I mean, how bad is it?
I'm not sure, but I realized that he coughed multiple times, and that until his face become red.
Oh, okay. Is there any shortness of breath or bluish discoloration of lips and extremities come along with the cough?
No.
No. All right. Okay. I want to ask regarding the runny nose. Is there any discharge?
Clear nasal discharge.
Oh, okay. Did you notice any blood or mucus in the discharge?
No.
No. Okay. For both cough and runny nose, is there anything can aggravate or relieve the symptoms?
No.
No. Okay. For the fever just now, is there any rash?
No. I think there is no.
Nausea? Is there
No.
any nausea? Is there any rapid breathing, headache, or ear discharge?
No. I think there is no.
Okay. Thank you. Okay. You also claim that your son developed the episode of eating. May I ask, is this first time this happened? And
Yes.
how? Okay, sorry.
Yes, this is her first time. His first time.
And how was you notice the eating?
I noticed it after he drink the bottle milk, and then I also noticed that there is some jerky movement of the upper limb, rolling of eyeball, and drooling of saliva.
Okay. Um, is he urinated or defecate during the feeding?
I'm not sure because he was wearing diaper at that time.
Okay. How long did the feeding lasted?
I think it's about 5 minutes.
5 minutes. Okay. How he gained his consciousness?
He regained his consciousness after I called him multiple times.
Does he respond to you?
Yes.
Okay. How was his condition after the beating?
After the fitting, he was tired and sleepy. So I was worried because of that and decided to bring him to the hospital.
Oh, okay. You bring the hospital. Okay. At the hospital, did you know his temperature during that time?
I think I asked the nurse in charge and the temperature is about 39.9.
Oh, okay. May I ask, did the doctor at the hospital told you anything about your child?
I think the doctor said that the tonsil were injected. The tonsil of my son were injected. So he gave my son paracetamol.
Okay. Is there any head injury just before the fitting?
I think no.
No. Is your son experience any neck stiffness or any irritability?
No.
No. Okay. Is he experience any sensitivity towards the light?
No.
No. Okay. Okay. Mrs. Ain, may I ask, is he ever been admitted before this due to the medical conditions other than this?
No, this is his first admission.
Okay. Does he get any surgical procedure before this?
I think no.
No. Okay. Sorry to ask. During pregnancy, have you ever been diagnosed with any disease like GD, like diabetes mellitus or hypertension?
I think no.
No. Okay. After birth, is he developed any complication?
If I'm not mistaken, my son had prolonged neonatal jaundice, so he had been given phototherapy for that.
Okay. May I ask about his development and growth? Is he developed like the normal children or a bit slow at his age?
I think compared to his friend, I think it is normal.
Okay. Is he had regarding his feeding? Is he already ate any food? And does he drink formula milk or breastfeeding?
It is semi-solid, and he is still on formula milk and breastfeeding until now.
But just now he reduced in the oral intake, right?
She had.
Is he had any medication prescribed for him?
No, but before this, that like I say that the doctor give paracetamol. Except for that, no.
Okay, thank you. Is he has any allergy towards any drugs or food?
No.
No. Okay, Mrs. Ain. May I know how many children do you have? And Ahmad is the
I have 3 children, and Ahmad is the youngest one.
Oh. Is there any of your children had any disease other than him?
My first child had eczema, and my second child is healthy.
Okay. Do you and your husband has known medical illness or chronic disease?
No, we are healthy with no known disease.
Okay. Is there any family members with the history of fitting before this?
No, there is no family history.
Yes, him. Okay. May I know what is your and your husband occupation?
My husband is a businessman. I am a government official.
Okay. Since both of you working, who will look after your children?
We hire a maid.
Oh, you hire a maid. So your household members is about 6 people, right?
Including the maid.
Okay. Sorry to ask this question. Do you and your husband smoking or drinking alcohol?
My husband is a chronic smoker, but he is not drinking alcohol.
Mrs. Ain, may I know where do you live?
I live at Semambu.
At Semambu. Is the environment okay? Is it near the factory or dengue-prone area?
No.
No, environment okay. Okay, that's one. Recently, did you travel to any places?
No.
No. Okay. I think that's all I want to ask you. Thank you, Mrs. Ayn, for your cooperation. I hope your son is getting well. Thank you.
Okay, can you summarize for me, please?
Okay. Summary. Ahmad, 1 year, 8 months old.
Don't repeat.
Okay.
We don't need to repeat all, please. Just summary.
Okay. Ahmad, 1 year, 8 months
Okay.
old, Malay boy with no developmental delay, presented with fever of 1 day duration and 1 fitting episode. The episode of fitting lasted around 5 minutes. There was uprolling of the eyeball, rolling of the saliva, and jerky movements of the upper limbs during fitting episode. There is no photophobia, neck stiffness, headache, nausea, and vomiting, and also the ear discharge. The fever did not subside. The fever associated with the cough and runny nose. At the emergency department, The doctor thought that the tonsils was injected and he was being prescribed with the syrup paracetamol. Otherwise, others were normal.
Okay, so what's your working diagnosis now?
So my working diagnosis is simple febrile seizure secondary to tonsillitis.
Any background for the child? He has any abnormalities?
Okay, he
His
had
development are normal?
developmental, no. It's normal.
Sorry,
Normal developmental.
it's normal. So what is the difference between simple and complex or typical and atypical?
Is it about the duration of the seizure? Like for the simple, it is less than 15 minutes. But for the complex, it is more than 15 minutes.
Is it the only difference?
No, there is others.
Yeah, if you have other, you must give it in one shot. We have 4 criteria, 3 criteria for differentiating simple from complex.
Doctor,
Don't
give it.
May I answer? Okay, about the nature, the simple, it is generalized tonic clonic seizure. But for the complex, what we call there is a focal seizure usually. And for the recurrence, usually.
So if it is.
Okay, doctor.
Yes.
For the recurrence.
Good, continue.
Usually, the simple, there is no recurrence within 24 hours periods. But for the complex, it may reoccurs within 24 hours periods. And for the post, I don't know how to say, post-ictal gestures, I mean that after the seizures, for the simple, usually there's none effect. But for the complex, they may have some complication like the residual neurological deficit. I think there's the 4 main criteria to differentiate.
So if
okay,
so this is a very important to know complete differentiation between different landmarks. Okay, you must be very clear. What is your differential diagnosis other than simple febrile seizure?
Other than that, okay, I show the slide. Okay, I have the meningitis, encephalitis, and also the hypoglycemia.
The knowledge in the brain, not in the book.
Okay.
The knowledge must be in our brain, not in our book only.
I have the my differential diagnosis are
not need to. Nadia.
Yeah.
You are not in need to read. I need to answer from you. You prepared it before. I need to listen to you now.
Yeah.
What is remaining in your memory?
Meningitis.
So what is the differential diagnosis now?
Meningitis.
Okay.
For the meningitis, because.
So how can we rule out?
Because the patients had a fever and also seizure, but the patient did not have any photophobia or neck stiffness, and also the headache. For the encephalitis, same like the meningitis, like the patient had the fever and also the seizure, but the patient does not have the headache, nausea, and vomiting. And for the last one is the hypoglycemia.
Who said like that?
For the hypoglycemia, the patient is lethargic, loss of appetite, but I think there is no what we call irritability, and from the investigation from what I read, for the random blood glucose, it does not indicate the hypoglycemia.
So the most important, Nadia, is just to say for any diagnosis, I have history, clinical examination, and investigation. Okay. So what is the clinical manifestation you suspected to find if the patient has meningitis?
First, from what I read, there's in the meningitis, there's no specific symptoms like the headache, malaise, fever, and seizure. But for the specific symptom, we had the triad, which are the neck stiffness, photophobia, and also I think headache once more. Yeah. So from this
Signs and
signs. For the signs,
about the signs.
About the signs, maybe
What are the signs of meningitis?
Brudzinski and Kernick signs.
Yes, and neck stiffness, and very important, is there any rash, specifically berberic rash? Berberic rash are very, very important.
Okay.
Okay, so I would like to ask now, نقي الدين. أفيك نقي الدين?
Yes, doctor.
Where are you? What is the differential diagnosis of convulsion generally? If someone told you that it has convulsion, how you are thinking? Sorry?
Epilepsy.
What is epilepsy, Naqiyuddin?
The occurrence of the unprovoked seizure.
No, the voice is not clear.
Hello?
What again?
The occurrence of the unprovoked seizure. Hello?
Yes.
The
I can hear
occurrence
you.
of the The occurrence of the two unprovoked seizure within the 24 hours.
You want me to add?
Sorry?
Anyone need to add? Azreen Farhana.
No, doctor, that's all.
So if you have any patient with convulsion, how you are thinking? You must be able to define, is it febrile or afebrile? Okay, with afebrile maybe got with some infection, some like that, meningitis, encephalitis, simple febrile seizure. But if it is not febrile, like your colleagues speak about, like epilepsy, we must know that it is unprovoked, repeated convulsion. Okay, which is very important. It must be repeated more than once. I cannot diagnose epilepsy if the patient has one attack only. Okay, because epilepsy is a clinical diagnosis. But now we are speaking about other causes which can cause convulsion for Hana. Nadia speak about the simple or complex febrile seizure, and she spoke about meningitis. Is there any other causes? Also, your colleague Naqib speak about the can be epilepsy if there is no fever and recurrence, and there is recurrence. What else we must put in your differential diagnosis?
Hypoglycemia.
Hypoglycemia, so it can be metabolic. Many causes like hypoglycemia, hyponatremia, hypokalemia, all this also can affect, especially hyponatremia. It's very famous to good consumption if less than 120. So it can be metabolic. Okay, what else? So we speak now about infection. We speak about hypoglycemia, which is one of the metabolic. We speak about epilepsy. What else?
Trauma.
Kidney.
Very good. So this is a good point now. We must come back to our basic clinical science. What is the pathophysiology of any disease? It can be infection. Yes, it can be traumatic. If the baby got trauma and has IVH or like that, it is very important. It can be infection, like we are speaking about meningitis, encephalitis, or others. It can be also malignance. It can be brain, okay, increase in the intracranial pressure, either due to tumor or to other. So it is very important. It can be end organ failure. The patient has like chronic renal failure and he got hypertension. If the patient has glomerulonephritis and got encephalopathy due to fluid accumulation, so we must know all about that, okay? And even sometimes if the patient has some autoimmune diseases like SLE, he can get convulsion due to this inflammatory process. So your rule always to remember what is the pathophysiology of the disease you are getting it. I was suspecting from your colleague to tell me what is going with the patient of asthma, why he got wheezes, what is the mechanism of this one, and what is the role of our medication. This is very important. Also here, we must know the differential between the simple, the complex, the convulsion with fever, convulsion without fever. What is the basic investigation we need to do? Okay? You can continue now, Nadia.
Okay. Doctor, do we need to discuss about this?
I need to see the clinical findings first.
Make a finding. Okay, sorry. So, okay. This is from just now about the story, and this is from the systemic review. And this is about the past history.
No, come back to this slide, please. Come back to the slide. To the previous one.
Okay.
No dysmorphic, no dysmorphic features. The clinical findings, please. Yes, continue the next.
Okay. This one.
Okay, come the next.
Next.
No, the next one.
Next one.
Okay, next. Yes, here. Negative findings. Okay. You cannot hear me, please? I would like to tell you that there is a very important in the clinical. I need now to insist about your clinical skills. Come back to the one which you specify the result, the clinical examination. Come back again 2 or 3 slides, please. Why you are very running? The one before.
Oh.
One before.
Okay. Sorry. Okay.
One before. Very good. One before. Yes, start from here now. This is our physical examination. Okay. Negative. Astaghfirullah. Come to the same slide. Why you are changing it to history now?
Sorry, doctor.
Here. Stop here, please. Yeah, Nadira, come to the previous slide, not this one. To the same slide before.
Which one's, doctor? Is it?
The one before we are just present negative. Allah, I was taking my time.
Doctor, sorry.
Come back, please. Come back. Come back, please. You can hear me or not? Or you can, yes, here, this one. Start from here. Now we are speaking about physical examination. Okay? It is very important to consider a lot of things here. Okay? The general look of the patient. You speak about that he is alert and not tachypnic. It is very important. Non-dysmorphic. Okay? No pallor or cyanosis. No head swelling. You must know for everyone what does it mean for you. What does it rule from our diagnosis, okay? No high arched palate, no lymphadenopathy, no finger clapping. It is not enough. I mean, some negative findings are very important. You must say there is no neck stiffness, okay? There is no rash in the skin. So we can go for the next slide, please. Next slide. Yes. Don't forget that vital signs are very vital. You mustn't miss it in any patient. Good. So most important here, sometimes we can find one child with hypertension and he come to our emergency department due to convulsion. It maybe has like glomerulonephritis, post-streptococcal glomerulonephritis with hypertension, which cause, okay, encephalitis, encephalopathy for the brain. Good. Next one. Next slide. Yeah, you see? No, stand for the previous one, for the previous one. Yes, very important here, the physical examination also. For the system, we are searching what can be the cause, but our top priority is to rule out if there any CNS problem or not. So, as Nadia spoken here, no neck stiffness. It is very important. Motor examination, which is a nervous system, and the Babinski are very important. But she also specify that Brodzinski and Kernig's are negative. This is a very important. You must know how to do Kernig's and Brodzinski. I hope you present it in one slide after that, okay? Which are very, very important. The other system, I am going to rule out other causes. Continue. You can continue your presentation, please.
Again, I already explained about this.
Okay.
So this is the discussion. So basically, you must know the definition of the febrile seizure. So febrile seizure is the seizure that associate with a fever, and the important point is the children between 3 months to 6 years old, and in whom there is no intracranial pathology or metabolic derangement, and also the what we call the difference between the simple and complex febrile seizure, and also the causes. I think we already discussed about this. And also we must know about the term febrile status epilepticus. Febrile status epilepticus is when the seizure occur lasting longer than more than 30 minutes, and it is continuous or intermittent seizure without any neurologic recovery. So this is the pathophysiology. So from the infection and that cause the fever, or also the familial or genetic susceptibility that can elevate the temperature. So this will impact the ion channel, whether there is increase in the glutamate or decrease in the GABA, and this will increase the excitability and synchronization of the activity, and this will lead to the febrile seizure. So the complication, so this complication which are the recurrence and also the subsequent epilepsy. So this is the risk factor, the person who are higher risk to have the recurrence and also the subsequent epilepsy. So like this, family history of febrile seizure, age less than 18 months, a low degree of fever, less than 40 degrees Celsius, and brief duration, which is less than 1 hour between the onset of fever and seizure. And also for the subsequent epilepsy, neurodevelopmental abnormality, complex seizure, and also family history of epilepsy. So for the management, first, for the febrile seizure, we need to control the fever. Um, we must ask the patient to avoid the excessive clothing and use the antibiotic like the syrup or paracetamol 15 milligram per kilogram 6 hourly for patient comfort. Actually, for this patient, as you can see in the positive finding just now, there is IV granula at his hand. He was given with the antibiotic because the fever did not subside. And for the parents of children, we should, with a high risk of recurrent febrile seizure, which should also be supplied with a rectal diazepam, and they should also be advised to administer if the seizure lasts more than 50 minutes, and the family should be taught the first aid management of seizure. I think for the OSCE, I will pass to the Ain to present.
Okay, Assalamualaikum. I will proceed to the OSCE. Next. Nodi, next. Okay, so the first question is, this boy of 2 years old was presented with the fever and seizure without any abnormalities noted and was brought to the clinic. So the first question is, state your diagnosis. So what is your diagnosis? What do you think is the diagnosis of this patient?
Febrile seizure, but we do not know the simple or complex febrile seizure. I think I just know maybe it's febrile seizure.
Because we just say that it is a febrile seizure because we don't know the characteristic of uh, the types. So what is the characteristic of that diagnosis? So as like siapa nama? Nodi present before the characteristic of that diagnosis.
This patient because he has fever and also seizure. So I think that's the characteristic of diagnosis because yes, seizure. So we can say that he has fever seizure.
Yes, true. Nodi, can you proceed to the next slide? Okay, so this is the answer. So as you can see, it is a febrile seizure. So we don't know either it is simple or complex because there is no characteristic mentioned, and there is no characteristic mentioned. And for the characteristic of the diagnosis, which is the febrile seizure, is a seizure associated with the fever, commonly seen in 3 months until 6 years old, and there is absence of intracranial pathology. So that is the characteristic of the febrile seizure. Let's proceed to the second question. Okay, a picture shows a child that having febrile seizure. So name 2 types or classification of the above condition.
Simple and complex febrile seizure.
Yes, Azrin, it's true. It's a simple febrile seizure and a complex febrile seizure. And how to differentiate between the simple and the complex?
Like we discussed before, for duration, simple febrile seizure lasts less than 15 minutes and complex more than 15 minutes. And the nature of simple febrile seizure will be generalized, tonic-clonic. Meanwhile, for complex, it is focal in nature. And recurrence, for simple seizure recurrence, there is no recurrence within 24 hours period, but complex can reoccurs.
Okay, good.
Reoccurs.
Next study. Okay, so like Azrain said before, classification of febrile seizure can be simple and complex, and we can differentiate between the duration, nature, and the recurrent. So as you can see, for the simple, it's less than 50 minutes, generalized and no recurrent, and for the complex, it's more than 50 minutes, focal and reoccur, and also has post-ictal or after seizure gesture. Next. Okay, so a girl was brought to hospital due to seizure, which is associated with fever for more than 20 minutes. Within that period of having fever, her mother mentioned she was developed two seizures before. So state your diagnosis. Anyone? Diagnosis? Okay, I think we can proceed to the next answer because I didn't. Okay, so for the diagnosis, it is a complex febrile seizure. So as you can see in the question before, it stated that the seizure lasts more than 20 minutes, which is it has the duration is more than 50 minutes, and also the mention, not sorry, the mother mentioned that she had developed two seizure before. And for the clinical features, because it's a complex, so the nature itself is a focal. So, and it is based on the underlying focal seizure. So if the parietal is a numbness, tingling sensation, or at the temporal is the deja vu, and at the frontal is a wave-like sensation in head, and at the occipital is a visual disturbance or has a hallucination. And so for the complication of above condition, which is the febrile seizure, it can be epilepsy or the recurrent of the same illness. Next question. A picture shows a child that has been confirmed by doctor having febrile seizure. So state to either diagnosis. So anyone? Did they ask?
Meningitis. Meningitis and encephalitis because the fever and also the seizure.
Okay, next, mention briefly about the pathophysiology of that diagnosis. Okay, I think I can explain the pathophysio. So next. So as I said before, for the differential diagnosis, there are many causes of the seizure, either infection, trauma, or metabolic. So for the infection, it can be meningitis or encephalitis. Also for the trauma, it can be brain injury, which is a head trauma. And for the metabolic, it can be hypoglycemia, hypocalcemia, and hypomagnesemia. So mention briefly about the pathophysiology of that diagnosis. So as you, Nadia said before, the Okay, so as Nadia said before, the febrile seizure can be physiologic or genetic susceptibility. So this physiology and genetic susceptibility can lead to elevated body temperature. And this elevated body temperature can increase the glutamate, which is the excitatory receptor, and reduce GABA, which is the inhibitory receptor. So too much excitation and too little inhibition can cause a high excitability of neuron transmission, and this can lead to the febrile seizure. So I think that's all for the OSCE. Doctor?
Slide which speak about which part of the brain
Yes. Yeah, I want to ask
is
you
affected.
regarding this question. So from the PET protocol, I found out that for the focal, for the complex febrile seizure, the nature is the focal. So as you can see, for if the area of the brain affected is the parietal, is cause numbness and tingling sensation. So I want to ask regarding how want to know the from the clip, I want to know the the symptom of this because the child don't know. how to explain it.
Yeah, inshallah. Soon you have about 1,000 a day. You can choose after that what is your subspecialty. But I would like to ask you, parietal will cause some of tingling sensation, okay? For the temporal, what is déjà vu? Déjà vu?
Deja vu is like, it's like we think it's happened before.
Yes. The frontal, okay, will give wave-like sensation in the head, and the occipital can affect the visual because this is the distribution of the brain function. Okay, this is just to give us as a clue. It is not conclusive really. When you are doing after that the EEG, which is electroencephalogram, will define for you which part are affected by the abnormal electricity. Okay, which is very important to guide us. The most important here, as I told you, we need to rule out an important diagnosis, and we must put in mind that some negative signs are positive. I mean, you need to add like what is the symptom and signs of increased intracranial pressure. You just finished it in your basic. It will be more easy for you even than fifth year. What can be the cause? What is the sign and the symptoms? It is very important for us because sometimes you need to diagnose that if the patient has headache in the early morning and it can awake him from sleep, if he is just putting his leg to his foot to the floor and feel that there is severe pain during this step. A lot of things, if he has vomiting, if he has, we must take care about increased intracranial pressure, okay, which is sometimes is accommodated or sometimes is just a benign increase in the intracranial pressure. But if it increased, it can affect the patient even and go for coma like that. I think you did, is it the all or still you have any clinical signs like Kernig's, Brzezinski, how to do it? Nadia?
Yes.
Nadia, you can just open Mr. Google for a picture of Kernig's and Brzezinski signs, please.
Okay. So I think for the Kernig, it is performed by having the patient in the supine position with the hips and knees.
Can you
Open the Google.
send now image for your colleagues so you can see it?
Okay. Can you guys see my Google?
Not yet.
No.
No. Okay.
We can.
Wait. Okay. For the Kernick sign, is performed by having the patient in the supine position, and we have the hips and also the knees flat, and then we extend the leg extensively, extend the leg passively, and the test is positive if the leg extension causes the pain. You can see in the picture. And for the Brudzinski sign, it is positive when there is passive forward flexion of the neck. You can see that the person lift the neck. That causes the patient to involuntarily raise his knees or hip flexions. So, it means that in the Brudzinski sign, it is positive when the doctors the passive forward flexions of the neck, and this can cause the patients to involuntarily hip and knee flexions. That is the Brudzinski sign positive, and this is the Kernick sign.
Is it clear for all of you about how can you do the Kernick's and the Brudzinski, also to rule out any neck stiffness, which are very important also, because all these are important signs of increased intracranial affection. Okay, good. Just document that and try to practice it. Okay, which are very, very important. Besides, as I told you, if the patient has any rash, specifically berberic rash, which is which can cause caused by pneumococcal or meningococcal, are very important. And even sometimes even the rash of some common disease like dengue fever can cause also meningitis as a complication, or hand, foot, mouth disease, which are very important. Of course, what is the LB result differential diagnosis? We may speak about it in our procedure, but we must know also how to interpret the CSF to diagnose different causes, either bacterial or viral or other, or partially treated, or TB, meningitis. It's very important. Okay, so you must add this to your presentation.
Okay.
Anyone has any other question?
Doctor, actually, I have one question. I think this is simple question, but
Yes.
may I know what is the differences between the meningitis and also the encephalitis?
Yes, that's a good question. What is meningitis by name? Itis means inflammation in the meninges. Okay, what encephalitis? It is now inflammation in the brain tissue itself, in the cerebral cortex. Okay, what is meningoencephalitis? It is now combining both of them. Okay, usually meningitis is in front of your eyes. Most of it are stiffness, neck stiffness, Kernick's positive, Brudzinski positive, and the most important, in a small baby, it will be bulging anterior fontanelle. It will be bulging anterior fontanelle because this Kernick's and the Brudzinski is not working in the first year of life, especially if the brain, if the anterior fontanelle is still open. So I can feel the increase intracerebral through the anterior fontanelle, it will be bulging. It is a very important sign also, okay? For encephalitis, it will affect the brain. I mean, I will start, the patient started to get like photophobia, abnormal behavior, okay? All this is related to the brain itself. So if I found it is either meningitis or encephalitis, or most common, we can find it mixed together. I mean, there is a sign of meningitis, but also I can feel that the patient cannot his eye in the light and he's avoiding light. He has abnormal behaviors like that. At that point, many clinicians prefer to start antibacterial and antiviral because most of the infection of the brain of the meninges are bacterial. In the brain, it is viral. So they add like ceftriaxone or cefotaxime plus acyclovir, which is the most common herpes simplex infection. Okay.
Okay. From the lumbar puncture, we cannot differentiate.
You still can.
Still can.
You still can. For the lumbar puncture, the pressure and some characteristic, you can add one complete slide, please. How can we differentiate between encephalitis and meningitis?
Okay.
It's very important to add again to the presentation. Okay?
Okay, thank
They
you.
are very important. Okay. So now we already spoke about two systems and the two very common, which is cough and with the chest and its differential diagnosis. And we speak already about the convulsion, which is accompanied by fever and what may be the presentation. I think again, I will give you a chance to revise what is the pediatric protocol also. Like for asthma, you must go through the febrile convulsion. It is very clear inside your pediatric protocol, and its other differential diagnosis like epilepsy and other you will find in the same chapter. You must go through it, and please give me feedback that you already done it. Okay, through WhatsApp message, please, by your group coordinator. Okay, who is your group? It is Noreen. We need to make sure that, yeah, we need that all of you finish that two parts, please. And for any presentation before, please try to go through your pediatric protocol. It is a good nourished, balanced diet. Don't miss it, please. Okay. Your marks today for both Amira is 6 and also Nadia is 6. Please, we need to improve a lot, inshallah, hoping we can be pioneer with time. I know that this is a starting point. Let us see, inshallah. Did I asked you before to prepare systemic examination like that? The flow for systemic examination? Or not?
Systemic examination for the disease, is it?
Yeah, how to do full examination of the heart, the chest, the abdomen, the nervous system, the joints, like that. Okay, let us let the representative of year 3 just contact me, please. Okay, who is that? Who is the representative for year 3 now for dispatch?
For our group, I am the representative that contact you, doctor.
You are representative for the whole batch?
No. For our group, our big group, the representative is Wakar, Zulwakar.
Zulwakar is for the whole batch, and you are for the group. Okay?
The whole batch. For
Yes.
the whole batch, Suhaib, doctor. Suhaib, okay. The whole batch. Suhaib. Suhaib and Najwa.
Good, good. Okay, that's fine. See you again, inshallah, hoping it will be opened and we can do it face to face, inshallah, which is more applicable and more, inshallah, beneficial. Okay, we can now our session. بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الصالحات وتواصوا بالحق وتواصوا بالصبر وصلى الله وبارك على سيدنا محمد وعلى آله وصحبه وسلم. السلام عليكم. See you soon.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Soon in the hospital.